Thank you very much. We're switching gears. We're moving to the clinical part of ophthalmic science. And I have a confession to make. I am a spelunker. I have been spelunking for some time and stealing time from my patients and mostly from administrative duties to play with the Topcon Tridon. And we're going to see what came out of it. Okay, so the first message here is that there are optically empty cavities in some eyes, and that's where you can go cave exploration, go on cave exploration, which is what speleology means. And retinal detachments, for instance, produce optically empty cavities. And here's an example, and those of you who are clinicians will have a hunch of what this is. Let us point to some crucial features like the stalactites hanging from above, the stalagmites at the bottom. Those are believed to be remnants of photoreceptors that fail to be phagocytosed by the RP because of the loss of contact. Then we have granular aggregations of such material. We have some atrophy of the outer photoreceptor structures. And we have a huge choroidal vessel right underneath a small pigment epithelium detachment. So obviously, and furthermore, here is a strand of fibrin that is connecting down to the pigment epithelium detachment. So this must be central serous chorioretinopathy. And let's look at it in this 3D rendition produced on the Topcon Tridon. And we can turn it step by step, as you will see at the exhibition. And here's that huge bulge seen from an angle as though we were standing inside the eye. And we can rotate it a little bit, a trick that can be used to produce stereoscopic images. We can put handles on it, and then we can peel away layer by layer as though we were slicing bread. And here you see the cavity from the top of the eye. Actually, it's from the feet, I believe. We can move in, look at the bottom of this cavity, and see that it's cobbled because of all the debris from the photoreceptors. We can shift it, and we can twist and turn it so that we see the floor or the roof as we have it here. We can look for the strand of fibrin that extends from the pigment epithelium detachment to the peak of the dome. It's right here in the middle of the cavity. We turn it again and move it around and get a good impression of the pile of debris and the pigment epithelium detachment at the bottom. Here's the strand right in the middle. I'm not sure that, yes, there is a pointer. You can't see it from down there. And then we move on and summarize the features of the structural OCT, the B scan, and the 3D rendition is composed by lots of parallel B scans that are put together and stacked, and this is possible because the swept source is uniquely fast. And the way it was introduced at our institution in Copenhagen, we saw it merely as an OCT angiography instrument, but there's a lot more in it, and these scans are very fast and very, very convenient for visualizing and examining patients and their diseases. So here's a neovascular pigment epithelium detachment, and let me just, it's seen from below. But by turning it a little bit and seeing it from different angles, you get an impression of how the new vessels come from the top of the image, from the choroid, and then they creep up on the backside of the pigment epithelium detachment. Very, very illustrative, and great to have together with OCTA because it gives you that three-dimensional impression. And at some point, I'm sure that the OCTA information is going to be embedded in the structural 3D presentation so that you can change the transparency and see the vessels inside. It's just a matter of programming. Am I right, Carl? Yeah, yes, thank you. And here's the OCTA. Here's a branch retinal vein occlusion case, and you're all looking for the occluded vein. It's a bit superior and nasal to the fovea, where we have hard exudate. And if you do an angiogram, an OCT angiogram, you can see that there is a coil of distorted vessels right at the spot where you can figure out that the exudation is coming from. And here it's in the crosshairs. And now let's see it from outside before we creep into the cave. And there's a nice illustration of the foveal depression and the vitreous detachment, partial as it is. And now we have taken the top, we have cut the top of the retina, and we look into the cystoid edema, which appears here like it is connected spaces. I'm not sure that the resolution is high enough to prove that point, but there's certainly a lot of fluid, and it's all coming from that structure in the middle with the high reflectivity. And we can have a look at it in a transection from both sides, where the aggregate is down below, and we can creep under the carpet, so to say, and move through the cysts, and then you'll see there in the middle of the picture that again the exudating tuft or bundle of vessels is extending deep down into the outer nuclear layer. There are some artifacts to be aware of. For instance, here you have a shadow which is cast by the blood moving in two vessels at the top of the image here, and it produces what looks like two tunnels underneath them. It's a good sign because the reflectivity of the blood is high when you have blood that is flowing. If it comes to a standstill, then the reflectivity will go down, and you can diagnose conditions such as ocular ischemic syndrome. And here's a patient who has sort of like a Stonehenge underneath his macula. Look at the black dots here in a semicircular ring, and here they are, pigmented they appear, although that may be a matter of reflection, of retroillumination. And let's look into the cave here. Here we have taken the lid off, and you see Stonehenge under the macula, and this is the roof, and here is the chronic serous detachment, and the strange debris may be pigment epithelium proliferation underneath it. Then what's the cause of all of this? Let's look down into the optic nerve head, and surely enough, we have an optic pit, as many of you already noticed on the first slide. So here's a connection from the cerebrospinal fluid up to the vitreous and down onto the retina. So these are some of the wonderful things you can see with 3D rendition. And I think the problem with OCT, as Professor Drexler also showed it, is that it's developing so fast that we don't have time enough to learn all the wonderful things you can actually do with it before you have the next generation of instruments. So I encourage my residents to do OCT themselves, because nurses are never going to figure out the mysteries of the retina that you can actually unravel with this beautiful instrument. And so here's a drusenoid pigment epithelium detachment with an RPE tear, and have a look at this. Strangely depigmented. You may think that there is new vessels underneath it, but and this is autofluorescence, and now you understand that there is an RPE tear because we have lost the autofluorescence in a very well-defined round area in the middle of the macula. And here is the structural OCT with enormous drusen, and to the left, the rolled up pigment epithelium. And let's have a look at this again in 3D. Okay, see it first from the outside, and then we cut off half of the retina up to the fovea nearly, and here you have these big boulders of drusen, semi-detached, floating around after the pigment epithelium detached and ruptured, and they can be seen from different angles, as we have it here. And that gives a good stereoscopic impression. But you can get even more stereoscopic impression by producing a rendition in 3D. So if we can get this out at the presentation, then you'll see that if you know how to squint your eyes, you can get a perfect 3D stereoscopic presentation of structures such as these. You can even do that in a film. And here's another patient where I was searching for a cave, but what I found was 2 depressions in the surface, here and there. And this patient is interesting because I saw him 19 years earlier with retinal vasculitis, and he had activity in those 2 spots, and now he still has retinal sensory defects where he has lost inner retinal tissue, but there has been no progression. And now we can do OCT, we couldn't do that 19 years ago, and look at the inner vascular plexus and compare that with the outer deep vascular plexus of the retina. And the difference is that here you have lost capillaries. So it all makes sense in a whole new and more insightful way than the old-fashioned types of fundus imaging did. 19 years after the infarction, solitary retinal vasculitis attack, wonderful insights. Here is one of the new items that have been described by Professor Kvarkus and colleagues, choroidal caverns. You can have optically empty cavities in the choroid, and here I have tried to show that in stereo and in pseudo-stereo by just moving around. You can see that here we have a cavity. It comes out better on a laptop, but when you go home and try this, you will find similar items, and you will appreciate the three-dimensional nature of these renditions. And here's another patient I call the valley between the hills, a 65-year-old male. He's had Lucentis every 4 weeks for 6 years. His visual acuity is still wonderful, 20/20, 1.0. And can you believe it? There must be CNV underneath it. Obviously, why would we have given all those injections? But the structure here is difficult to elucidate. The fovea is right in the middle. But I'll give you some more details. This is a vertical scan, and now we do the spelunking and climb through the retina after having looked at it a bit from above to get the 3D impression. And here we go. Cutting away, slice by slice, we see the structure of the vessels. And now here the shadow is so bright that there's actual loss of signal from the bottom of the structures. But there is a point to this, and we have also OCT in the instrument. And what you see here, down below to the left, is the noise signal from flowing blood, and corresponding with that, up there to the right, we have a monster CNV vessel, the biggest I have ever seen, and it was actually already there on the structural OCT, though I didn't realize it, namely right here. So what the arrow is pointing at is a tri-layer signal from flowing blood from a monster choroidal neovascularization trunk vessel. And with this appetizer for OCTA and three-dimensional OCT, I will stop my presentation for today. Thank you.